Welcome to this session, and today in our session of women's health, we're going to look at premature rupture of membranes. So, to get familiar with this topic, we need to understand certain terminologies which we're going to try and explain. And the first one is going to be term. So, term is simply the birth at 37 weeks or after 37 completed weeks. Okay, preterm is simply birth before 37 completed weeks, and latency is the time between membrane rupture and the onset of labor. Premature rupture of membranes is simply rupture of membranes at term, which is greater than 37 weeks, but before the onset of labor. Then we are going to also look at preterm premature rupture of membranes, which is simply the rupture of fetal membranes before the onset of labor and before 37 weeks. Okay, so just to put it into perspective, we need to understand to say uh, preterm premature rupture of membranes should be between 28 weeks but less than 37 weeks. That's when we consider it preterm premature rupture of membranes. Before 28 weeks, we consider it as an inevitable abortion. Okay. With that being said, when we're looking at the epidemiology of this condition, we need to know that premature rupture of membrane affects about 10% of pregnancies worldwide, and about 80% of women with premature rupture of membranes enter labor within 24 hours. Okay. The other thing we need to talk about is it complicates about 2 to 3% of pregnancies. Okay, so to dive deep into the risk factors, we need to understand how these risk factors cause or what can predispose women to having premature rupture of membranes. So, a previous history of premature rupture of membranes or previous history of preterm labor can predispose a woman to having premature rupture of membranes. Okay, so the other risk factor is increased membrane friability and decreased tensile strength. Okay, in certain conditions which affect collagen formation. So we have got collagen disorders. Okay. The other thing we can talk about is vaginal or intra-amniotic infection. Okay, such as certain bacteria such as E. coli, group B, streptococcus, so on and so forth. The other procedures, another procedure which can cause or introduce infection if not done properly is amniocentesis. Okay, so the other risk factor for premature rupture of membranes is cervical incompetence. Okay, because the amniotic sac is poorly supported, hence it can lead to rupture. Okay, other things which you need to consider is unexplained vaginal bleeding and also placenta abruption. Okay, so the other risk factors is smoking. Smoking causes rupture of membranes because it reduces formation of collagen, okay, or it affects the production of collagen. All right. So the other thing which can cause Prom is multiple pregnancies because it increases the intrauterine pressure, okay, which affects, which then causes micro tears and then brings about leakage of fluid from the vagina there. The other thing we can talk about is polyhydramnios. Okay, so polyhydramnios also increases the intrauterine pressure, hence causing prom. We also have certain drugs such as chronic steroid use, connective tissue disorders, anemia. All these predispose a woman to having prom. We also have certain factors such as low economic social status. When we're talking about low economic social status, we how it comes in is when a woman is lacking nutrients such as copper, zinc, vitamin A, it reduces the formation of collagen in the body, hence causing high chances of woman going having a prom. Okay, a low BMI can also contribute, and also short cervical length, less than 2.5 centimeters. With that being said, I would like to consolidate the information, and we're going to look at the pathophysiology of Prom. When we're looking at the pathophysiology of Prom, we need to understand that it's a multifactorial pathophysiology, in the sense that it has got about 3 interlinked mechanisms, okay, all of them which revolve around um, the withstanding normal intrauterine pressure. Okay, so Prom occurs when there's premature weakening of the amnion and the chorion, okay, making them unable to withstand normal intrauterine pressure. Okay, so the first mechanism we'd like to talk about is inflammation and infection. So the normal physiology of pregnancy is that it causes compression of urethral organs such as the bladder, and also other organs which are involved. So it can end up causing stasis there. Okay, so now what happens is that infections are going to easily enter through the vagina and ascend all the way to the cervix there. So there's going to be ascending infection from the vagina, and the most common bacteria which cause this to happen is group B streptococcus. We've got E. coli, we've got anaerobes. Okay, they may ascend from the vagina to the cervix, and also to the membranes. Okay, so the other thing we can talk about is the overstretching and the micro tears, okay, in the amnion, which can come about due to multiple pregnancies and also polyhydramnios, as we mentioned, okay, and also repeated stress can cause progressive weakening of the amniotic sac and eventually cause a rupture. Okay, so the other thing we can talk about is biochemical weakening and altered collagen metabolism. So there are certain things like nutritional deficiencies which account for predisposing a woman to prom. So we have got things like vitamin C, copper. Okay. So when a woman likes these things, maybe due to socioeconomic status or a poor diet, they can go into having leakage of fluid or a gush of fluid. Okay. The other thing which we can talk about is smoking. Smoking reduces collagen strength, and also oxidative stress damages the membranes. Okay, so all these factors lead to reduced tensile strength of the membranes, and they bring about increased rupture. Okay, which can cause a sudden gush of fluid. Okay, so the other thing we need to talk about is release of inflammatory mediators. Okay, so just to elaborate more on this, what we mean by release of inflammatory mediators: when there's an infection which ascends from the vagina and goes all the way to the cervix, is going to stimulate maternal immune cells to release cytokines such as interleukin 1, interleukin 6, and tumor necrosis factor alpha, and also prostaglandins and matrix metalloproteases. Okay, so all these mechanisms are going to cause enzyme degradation of the membranes, and the matrix metalloproteases are going to break down the collagen and the elastin. Okay, so with that being said, I hope the pathophysiology has been understood. And the other thing we need to consolidate on is how the mechanical stress on the membranes can cause or increase intrauterine pressure, can stretch and also weaken the membranes. So in conditions like polyhydramnios, there's excess fluid, okay, due to an imbalance between the absorption and the production. So this causes excessive fluid, which overstretches the membranes and eventually causes micro tears, and eventually causes a gush of fluid or leaking from the amniotic sac. So the other thing we need to talk about is the multiple pregnancies. Okay, so in a setting where they're twins, or in an instance where they're twins, there's going to be high uterine distension, which can predispose or cause progressive weakening or micro tears, and which can cause leakage from the cervix. We're going to also look at the other thing we can also look at is fetal presentation. In a breech presentation, there's an even pressure on the membranes, and that also can predispose a mother to having a prom. And also cervical incompetence, which can cause poor support of the membranes, which can also cause prom. Okay, so when it comes to the clinical features, I would just like to tell you that prom is made through made through a clinical diagnosis, and we need to take a good history and also do a good examination to ascertain our diagnosis of prom. Okay, so we need to differentiate it from hydroria gravidarum, which is just a periodic watery discharge, and urinary incontinence. Okay, and we need to ascertain that this woman has no significant bleeding. Okay, if it's present, we need to do an ultrasound and further investigate for placental previa. Okay, so in our setting, a woman will come to you complaining of a gush of fluid or continuous trickle of water, which is which is clear and which is coming out from the vagina. Okay, so when it comes to making your diagnosis, you're going to do it's basically based on the typical presentation of how the woman comes in. She will report of passing fluid per vagina or a gas sensation. Okay, so you need to keep in mind that our differential can be urinary incontinence. It can also be excessive physiological, or it can be an infectious discharge, e.g., it can be candida. Okay, so when it comes to the wake up, we need to do a sterile speculum, which is a gold standard. Okay, so we need to ask the woman to perform a cough reflex. Okay, so that cough reflex will simply show a spraying of fluid in the posterior fornix, and there's going to be visible fluid leakage there. Okay, so this is a gold standard, and when we're doing it, we need to maintain sterility because we do not want to introduce infections inside the vagina, because you're dealing with a woman who is already at high risk. And the other thing we need to talk about is when we need to do a speculum exam and inspect for cord prolapse. Okay, we need also to add on to make our diagnosis more certain. We can also do an ultrasound, which is just simply going to show reduced liquor, and also via the deepest vertical pocket and amniotic fluid index. Okay, you're going to see reduced liquor there. Okay, so we also need to do biochemical tests such as the insulin like growth factor binding protein 1 and placenta alpha microglobulin, okay, in the vagina, which is very highly sensitive and specific. However, we do not recommend some odd tests which were done in the past, such as the nitrazine test and the Fanning test, because these tests have been shown to give a lot of false positives. Hence, we have opted not to use them as frequently as we used to use them in the past. Okay, when it comes to the wake up and the investigations, we're going to do some maternal investigations. We're going to do a full blood count, okay, which is going to show us leukocytosis, okay, just a sign of infection, and C-reactive proteins, which are just going to show us, going to give us signs of inflammation, the inflammatory markers. Okay, so we're going to do a urinalysis, which is just going to be positive for leukocytes, and it's going to be a trace there. And we're also going to do a urine microscopy culture and sensitivity test. Okay, we're also going to do cervical swabs and cultures for chlamydia and Neisseria gonorrhea, and high vaginal swab for bacteria vaginalis and trichomonas. And we can also do a rectal swab for group B streptococcus. Okay. Um, so when we're doing all these swabs, our main goal for doing these swabs is we need to tailor our our investigations or the results to the certain antibiotics we want to use, so that we know which type of organism is growing there. So we also can consider getting a sample from the pooled vaginal fluid, okay, just to check for for fetal lung maturity. We're going to do a phosphatidylglycerol and also a lecithin fungomyelin ratio. Okay, so I'll explain more about these two tests for fetal lung maturity, and also we need to do a fetal assessment. You need to put the patient on a CTG or a cardiotocography, and also just to assess for any fetal distress, and also monitor the fetal heart rate, just to check for any variable decelerations. Okay, so when preterm delivery is being considered, as clinicians may sample a pooled fluid from the vagina or amniotic fluid to ascertain fetal lung maturity. And the two important laboratory markers are the lecithin fingomyelin ratio, which is indicative. If it's greater than 2, it indicates mature lungs. And we can also do a phosphatidylglycerol, which simply its presence confirms lung maturity. So these tests will help us reduce the risk of neonatal respiratory distress syndrome and guide our decisions during the time of delivery. Okay, so hope we've understood on that. Okay, so when we come to the management of Prom, we also need to know that after we've done our history and our examination, the woman confirms continuous draining of fluid, and the sterile speculum reviews pouring of fluid in the posterior vaginal fornix. Our plan is to admit the patient to the labor ward. We're going to monitor uterine activity and fetal heart rate. We're going to check the maternal pulse and temperature every 4 hours, and we're going to do cervical cultures for antibiotic prophylactic measures. Okay, as we mentioned earlier on, we're going to assess for signs of choriamnitis, okay, such as fetal tachycardia, maternal tachycardia, abdominal tenderness, and foul vaginal discharge. Okay, we're going to assess for labor and placental abruption. We're going to do an ultrasound for presentation and the anatomy, and also to also assess for liqua. Okay, we're going to avoid doing a VE in this type of patient because we want to reduce the latency period, and we want to avoid introducing infections in a woman who's at risk of having high infections. Okay, we're going to do our baseline, such as a full blood count, leukocytes, and a vaginal swab, just to check for bacteria and which type of organisms are growing there. Okay, so management is also tailored to the gestational age. The gestational age greater than 37 weeks. Okay, in the absence of infection, fetal distress, and choriamnitis, if the draining is less than 24 hours, we're going to manage conservatively and give them time to monitor the onset of labor. So when you give them time, we have to avoid unnecessary interventions, okay, because we want to lower the risk of infection. Okay, so when we have when we are monitoring them, we need to evaluate the vitals, the pulse, the temperature, the respiratory rate, and we do not do vaginal examinations. We just observe for uterine contractions. Okay, but if there are any obstetric comorbidities such as DM, diabetes mellitus, or severe preeclampsia, we need to induce the labor within 24 hours. Okay. Okay, so we can do a Caesar if there is a contraindication to induction of labor. But if there's no contraindication to induction of labor, if this woman does not go into labor within 24 hours, we need to induce the labor. Okay, So we do a digital vaginal exam. Okay, then we make our bishop score, or we grade our bishop score. If it's greater than 7, we need to induce labor with oxytocin, and if it's less than 7, we need to induce labor with misoprostol. Okay, so when it comes to these patients, we also need to put them on antibiotics. If the Prom lasts more than 24 hours, after we've observed for less than 24 hours, the patient is not going in, they are not they are not we're not inducing. Okay, if the and the labor is not starting when we have observed for 24 hours and it has lasted for more than 24 hours, we need to put them on antibiotic prophylaxis. So we're going to put them on drugs such as amoxicillin and amoxicillin 500 milligrams TDS, metronidazole of 250 milligrams QID, and amoxicillin 500 milligrams TDS as well. But in the absence of where we do not have metronidazole, we can also use erythromycin 250 milligrams QID until the patient delivers. Okay, so during labor, we need to monitor the maternal fetal heart. We're going to check for observe for reduced liqua. Okay, because we want to avoid cord compression. We're going to look out for infection when the baby is born, because there is high risk of them having neonatal sepsis or purpura sepsis and also chorionitis. Okay, so just to basically give a summary of what we've talked about in the management of these patients, we need to basically manage them according to the gestational age. So if they come at 37 weeks and above, or at 37 weeks itself, we need to make sure that if we look at the timing of the draining, is it greater than 24 hours or is it less than 24 hours? If it's less than 24 hours, you want to manage conservatively by just waiting for the woman to go into labor. And then if she lasts more than 24 hours, you need to start thinking of inducing. Okay, and then you do a bishop score, or it will guide you if you need to use oxytocin or misoprostol. But if there are any contraindications to induction of labor, you can then opt for a cesarean section. Okay, so that was management of Prom. We're going to look at management of premature rupture of membranes, or premature or preterm premature rupture of membranes. So after we ascertain our diagnosis and we do a good history, and we make a do a good examination using a sterile speculum exam, we need to uh, we need to start waking up how we're going to manage this patient who's coming with preterm premature rupture of membranes. Okay. So, initial management for these patients on admission, we admit a patient for close observation. We avoid doing a digital vaginal examinations just to reduce the risk of infection and prolong the latency period. We're going to do baseline investigations such as a full blood count. Okay, specifically, we're going to monitor for leukocytes. We're going to do a vaginal swab, which can be taken for microbiology. Okay. Though results may not always alter our management, because we'll still put them on antibiotics regardless. Okay. And also we need to check for inflammatory markers such as C-reactive protein, which are used for laboratory marker for infection. We also need to put these patients on antibiotic prophylaxis, such as we need to put them on erythromycin, about 250 milligrams or 500 milligrams every 6 hours. And duration, we need to continue up to 10 days until the onset of labor. Okay. Alternatively, we can use metronidazole as in some protocols, and we can also the benefits of using these antibiotics is that they increase the latency period, and also they reduce the risk of chorionitis and also neonatal sepsis. Okay, so we also need to give patients or put them on corticosteroids if they come to they present less than 35 weeks gestation. Okay, we need to put them on corticosteroids just to accelerate the fetal lung maturity by increasing the surfactant production. So this is going to help us reduce intraventricular hemorrhage and necrotizing um, enterocolitis. Okay, so the dosage for this dexamethasone, we give it at 6 milligrams twice daily for at least 4 doses. Okay, total of 4 doses. We also need to put the patients on all patients who are at the gestational age of less than 30. We need to put them on magnesium sulfate just for neuroprotection. Okay. We also, why we're putting them on on magnesium sulfate is just to reduce the risk of them having cerebral palsy and other neurological complications. Okay, so the other considerations we need to we can put them on anticolytic agents. Okay, just to reduce to delay labor. Okay, for for a short duration. Okay, so possibly we are putting them on tocolytics. If there's any contraindication, we need to avoid if the patient is developed an infection or if they have choromnitis is present, we do not need to prolong the labor because they are already having an infection. Okay. So now, how do we monitor for choromnitis? Okay, so we need to check the maternal vitals regularly. Okay, for we need to check for the temperature, the pulse rate, and we need to do fetal monitoring and watch out for fetal tachycardia. We also need to assess changes in the smell, the color, or any presence of foul discharge from the vaginal fluid. We also need to look at the uterine assessment. We need to monitor for new onset abdominal pain, uterine tenderness, or uterine irritability. Okay, so when it comes to the timing and the mode of delivery, we need to consider delivery at 35 completed weeks. Okay, though this should be personalized or tailored to each individual. Okay, so we need to also consider the stable latency. So if both the maternal and the fetal conditions remain stable, latency can be extended to 37 weeks. And we can also consider immediate delivery if there's development of chorioamnitis or their standard obstetric indications, okay, which might cause fetal or maternal compromise. Okay, so basically what I'm trying to say is that we can consider delivery at 37, at 35 completed weeks, or we can extend it depending on how stable the latency is up to 37 weeks. Okay, so the preferred mode of delivery is vaginal delivery. Okay, which is usually induced or augmented. The induction depends on our Bishop score. Okay, as we've mentioned earlier. And fetal monitoring, we need to continuously monitor the fetus during labor just to reduce the risk of oligohydramnios, cord compression, and we also need to watch for variable decelerations. Okay, so cesarean section is reserved for standard obstetric indications or any contraindications to birth delivery. Okay, so just a special consideration in the case of chorioamnitis, a cesarean section is generally avoided unless there is unless it's necessary. But we avoid the cesarean section with if a mother has chorioamnitis because it increases the risk of maternal morbidity, and which is goes against our rules because we do not want any woman to die while giving birth. Okay, so thank you very much for the time.